Welcome and thank you so much for joining our webinar today. Today's webinar will last around 45 minutes and then we'll have 15 minutes at the end for questions. We would like you to keep your mic muted and your camera turned off throughout the webinar just to avoid side noise. We'll open the discussion at the end of the webinar for questions and you can place your questions in the chat. This webinar will also be recorded and uploaded afterwards to watch on our YouTube channel. And we are absolutely delighted today to have Dr. Renée Mulder speak to our group. Dr. Mulder is a senior scientist and guideline specialist at the Prinses Maxima Center for Pediatric Oncology in the Netherlands. She's one of the founding members and coordinator of the International Late Effects of Childhood Cancer Guidelines Harmonization Group, and she's responsible for the development of cancer survivorship guidelines for that group. She's also a core member of the Pan-Care Guidelines group that coordinates the development and dissemination of survivorship guidelines within Europe. She also assists in the development of national and international supportive care guidelines. So she has a wealth of knowledge to share with us, and we're very excited to have her here today to talk about survivorship issues. She's going to speak about fertility preservation guidelines for childhood, adolescent, and young adult cancer patients.
So thank you so much, Mindy. So welcome, everyone. I will first explain some principles of guideline development and then go into details of the fertility preservation guidelines for the KA cancer patients. Yes. So everyone has the right to receive optimal quality of care. And to achieve this goal, several steps are necessary. So the first step is to perform clinical studies and summarize the results into systematic reviews. Clinical policy can then be made by integrating the evidence into clinical practice guidelines. And then based on the recommendations in those guidelines, we can evaluate quality of care. So these elements form the cornerstones of evidence-based medicine. So when people started to develop guidelines, this was mainly consensus-based. And since the introduction of evidence-based medicine in the early 90s, there was a shift towards integration of evidence when formulating recommendations. So within pediatric oncology, there are a lot of protocols in which there's no clear distinction between evidence and recommendations. And it is unclear where the actions to do are based on. So when you make an evidence-based guideline, there should always be a clear distinction between scientific knowledge and the recommendations. And to generate recommendations from evidence, several factors are considered. So the quality of the evidence, the clinical expertise, and patient values. So the US Institute of Medicine has developed standards for evidence-based guideline development and defines guidelines as statements that include recommendations that are intended to optimize patient care, that are informed by systematic review of evidence, and an assessment of the benefits and harms of alternative care options. So guidelines are seen as powerful tools to improve healthcare processes and health outcomes. So in many fields of medicine, care that is consistent with evidence-based recommendations has led to improved patient outcomes and more efficient care delivery. Also, guidelines facilitate uniform care and thereby reduce variability in daily practice. Also, guidelines can contribute to reduce healthcare costs by standardizing care and reducing unnecessary or inefficient components of care. So many institutions and organizations now recognize the need for clinical practice guidelines. So in 2010, the International Guideline Harmonization Group was founded to collaborate in guideline development. And the main goal is to establish a common vision and integrated strategy for the surveillance of late effects in childhood, adolescent, and young adult cancer survivors. But next to that, we now also focus on topics related to improved cancer survivorship, like fertility preservation. And by international collaboration in guideline development, we aim to combine international expertise to develop high-quality guidelines, reduce duplication of effort, stimulate consistent clinically effective care, and establish collaborative research goals. Our guidelines exist of three important components. First, we have the clinical questions that address important issues that need to be summarized by evidence. Then a summary of the evidence and grading of the quality of the evidence. And recommendations that are formulated based on the evidence, clinical expertise, and patient values. And now I will focus on the fertility preservation guidelines. So although fertility management in a cancer setting is seen as an important issue, previous research indicates that childhood cancer patients are not always adequately counseled about the risks for infertility and options for fertility preservation. And neither are they referred to on-call fertility specialists. Also, existing clinical practice guidelines for fertility preservation varied substantially, which led to variations in clinical care. And also, when we started to harmonize the guidelines, we noted large variations in recommendations between the different guidelines. It was, for example, unclear why, according to guideline A, a male patient who will be treated with low doses of alkylating agents is offered sperm cryopreservation, while in guideline B, this was not recommended to the same patient. And to facilitate a global consensus, we organized a multidisciplinary group of international experts to develop a transparent evidence-based guideline for fertility preservation for childhood cancer patients. So we organized 3 panels, one for female and one for male fertility preservation, and one for communication and ethical considerations. And these panels consisted of around 40 experts with different expertise. We also involved patient representatives who reviewed our recommendations. And the entire process took about 4 to 5 years, which was very time consuming. But people were super dedicated and involved, and that was very nice to experience. And because it involved experts from different continents, we organized many online meetings. After comparing the existing guidelines, we formulated focused clinical questions. We formulated questions covering the following topics. So who should be informed about potential infertility risk? Who should be counseled about fertility preservation? What reproductive preservation methods are appropriate to offer in counseling? And what are important issues relating to the discussion of issues, including ethical considerations? In a next step, we systematically searched for evidence. So we approximately reviewed about 10,000 abstracts related to male and female fertility and communication and ethical issues. And around 1,400 full-text studies were screened. For the 200 studies that were included, we summarized the evidence and graded this evidence, and that was done using the grade methodology. So this is a well-established methodology to determine the strength of the total body of evidence for each clinical question. And finally, we formulated recommendations based on the evidence, clinical experiences of the expert panel, patient values and costs. And using the GREAT evidence to decision frameworks, we can transparently make a balance about potential benefits and harms of different preservation procedures. And because this is an international guideline, we had to take into account that the recommendations are applicable to different healthcare settings. And then the recommendations that we formulate are divided into different categories. We have strong recommendations to do, where the benefits clearly outweigh harms. We have moderate recommendations to do, in which there is a higher degree of uncertainty, and strong recommendations not to do a certain action. We have developed 3 separate guidelines that were led by Leontien Kremer and chaired by Wim Tissing, Marianne van der Wetering, Jennifer Levine, and Lisa Kenny. And as you know, probably the manuscripts were published as a series in the Lancet Oncology. Well, I think that the majority will know this figure, but for the ones who are new in the field, I would like to show this. So female impairment of gonadal function results in primary ovarian insufficiency, which may present with primary or secondary amenorrhea, impaired pubertal development, or premature menopause. And in this figure, you can see the normal decline in ovarian reserve or number of follicles by attained age. And in this second figure, you see the effects of high-risk treatment. So the number of follicles drop dramatically, and childhood cancer survivors can go early into menopause much earlier than in the general population. So based on the evidence from our systematic literature review and expert opinions, we defined patient at risk for infertility. These include radiotherapy to the ovaries, alkylating agents, stem cell transplant, and ovarectomy. And regarding the alkylating agents, the studies that we have identified showed no significant increased risk below doses of 6,000 to 8,000 milligrams per square meters. And also patients treated with cranial radiotherapy are at risk for infertility. And although the gonadal function is not affected, ovarian function can be impaired by damage to the hypothalamic pituitary gland. Based on the evidence on risk groups, we have formulated recommendations about who should be informed about the risk of infertility and who should be counseled about fertility preservation. So the panel agreed that all cancer patients and their families have the right to be informed about their potential risk for infertility. And therefore, we recommend to inform every cancer patient about their potential infertility risk. And this obviously varies based on the planned treatment. And moreover, only those patients at risk, so that are the risk groups I just mentioned, should be counseled about fertility preservation options and alternative family planning. There are 4 fertility preservation procedures that were considered. So first one, oocyte cryopreservation for post-pubertal girls and females, ovarian tissue cryopreservation, oophoropexy or ovarian transposition, and the hormone suppression by GnRH analogs during chemotherapy for post-pubertal girls and females. So this is an overview of the recommendations for the female cancer patients. For every risk group, we formulated separate recommendations. So the highest risk group are patients treated with high-dose alkylating agents, radiotherapy to the ovaries, and or stem cell transplant. Then we have a group of low-dose alkylating agents and cranial radiotherapy, a separate group for unilateral ovarectomy, and patients who will be treated with other therapies are not considered as being at risk. So each fertility preservation procedure has its advantages and disadvantages, and the guideline panel carefully made up these balances for every risk group when formulating the recommendations. So this is a case of a 4-year-old girl with a soft tissue sarcoma. And according to protocol, she will be treated with high doses of ifosfamide. And this leads to being at high risk for infertility. And the only option that can be offered is ovarian tissue cryopreservation. So this can be performed when a girl is clinically stable before she has received the total cumulative cyclophosphamide equivalent dose of 6,000 milligram per square meters. So this is a moderate recommendation, and therefore it's extra important that potential benefits and risks are carefully balanced before undergoing such a procedure. And on this slide, you can see the balance of potential benefits and risks. So it is important to know that the collection of ovarian tissue is no longer experimental. The procedure can safely be performed in children aged 1 year and older. And there is an option to bundle it with other surgical procedures. And regarding the successful transplantation, we know from the evidence that at least 9 females diagnosed with cancer at a young age who underwent transplantation of cryopreserved ovarian tissue successfully gave birth to 14 healthy babies. So I should mention that this was the evidence from 2 years ago. So this number is most likely higher at the moment. Also, systematic reviews, including childhood and adult cancer and non-cancer patients, reported at least 86 live births thus far, with a success rate of around 45%. And as another benefit, there is a potential to restore endocrine function. But as a side note, there is still very limited evidence in childhood cancer patients. And regarding potential harms, there is a risk of intraoperative bleeding and the risk of primary ovarian insufficiency with the removal of the ovarian tissue. And regarding autotransplantation of prepubertal tissue, this is still experimental. And there is also a risk of tumor cell contamination in leukemia and non-Hodgkin lymphoma patients. So then the boys and the young males with cancer. Male impairment of gonadal function results in impaired spermatogenesis, testosterone deficiency, or central hypogonadism. And based on the evidence and expert opinions, we defined patients at risk. And these include radiotherapy to the testes, alkylating agents, cisplatin, stem cell transplant, and orchiectomy. And regarding the alkylating agents, so the studies that we have identified show that azoospermia was unlikely below doses of 4,000 milligram per square meter. And again, as for the girls and females, patients treated with cranial radiotherapy are also at risk for infertility. But again, gonadal function is not affected, and testicular function can be impaired by damage to the HP gland. So based on the evidence on risk group, we formulated the recommendations for who should be informed and who should be counseled. And like the recommendations for females, every cancer patient should be informed about their potential infertility risk, and only those at high risk, so listed on this slide, should be counseled about fertility preservation options and alternative family planning. Also, 4 preservation procedures for males that were considered in this guideline: the sperm cryopreservation by masturbation or vibration, surgical sperm collection by electroejaculation or testicular sperm extraction, cryopreservation of testicular tissue or spermatogonial stem cells, and hormone suppression. This is the overview of the recommendations for the males and boys. For every risk group, we formulated separate recommendations, also depending on the balances of advantages and disadvantages of the fertility preservation procedures. And the highest risk group are the patients treated with high-dose alkylating agents, radiotherapy to the testes and/or stem cell transplant. The second group includes the low-dose alkylating agents, cisplatin and unilateral orchiectomy, and a separate group for cranial radiotherapy. And patients who will be treated with other therapies are not considered as being at risk. So this is a case of a 7-year-old boy with a rhabdoid tumor of the abdomen. And according to protocol, he will be treated with high doses of cyclophosphamide. And this leads to being at high risk for infertility. So the boy is prepubertal, and the only option that can be offered is testicular tissue cryopreservation. And this can be performed when the boy is clinically stable before receiving this total cumulative dose of 4,000. And so before a patient family decides to undergo this procedure, the balance of harms and benefits should be carefully weighed. So studies have shown that mature spermatogonia and spermatogonial stem cells have been found in dissected testicular tissue, but there is still very little evidence about effectiveness. The procedure is experimental and there are no reported human live births thus far. And as far as I know, there are no transplantation has ever been performed in a childhood cancer survivor. Also, there are risks of surgical complications and potential reintroduction of malignant cells. Regarding the communication and ethical issues, there are some important considerations that need to be taken into account when communicating with patients and families and when making decisions about their future fertility. It is very important that counseling is initiated as early as possible and on an ongoing basis. Healthcare providers should actively involve patients and families, and fostering their autonomy is essential. And also shared decision-making is important when fertility preservation and future family planning decisions are made. Also, patients and their families should be informed about the potential benefits, harms, costs, and logistics associated with fertility preservation in order for them to make a well-informed decision. Patients may feel uncertain about their future desires and struggle with balancing the short and long-term advantages and disadvantages. And also we should be very careful with creating unrealistic expectations, as fertility preservation does not guarantee future reproductive potential. So now that the guidelines are developed, they should be implemented into daily clinical practice. And this is not an easy job and takes important efforts. So I work at the Princess Maxima Center for Pediatric Oncology in the Netherlands. And this is a national pediatric oncology center. We see around 600 new patients per year, and we have one mission, so to cure every child with cancer with optimal quality of life. And in view of this mission, we have established an oncofertility program and team. So the team is chaired by Marianne van der Wetering and includes expert oncology representatives from every unit of the Princess Maxima Center. The team also includes an oncofertility gynecologist, urologist, endocrinologist, and a clinical embryology team. Irene Eigelse, really a Dutch name, is our fertility nurse practitioner and fulfills the role of a patient navigator or case manager. And she's really essential for the success of the program. So based on the guidelines, she does the triage of new cancer patients using kind of a risk stratification tool or document, I should say. So this is a small snapshot of the risk stratification sheet that they are using at the moment. So for every cancer diagnosis, the treatment protocols, the specific therapies, and the cumulative cyclophosphamide equivalence dose are described. And then the fertility risk is determined based on the recommendation. So that is shown in the last column. And using this sheet, they are able to make a quick estimation of the fertility risk based on the guidelines. And then this is the flow chart that is used in our clinic for new, in this case, female patients. So first there's then the timely triage by the expected infertility risk. All patients will then be informed about their potential risk. And then the patient at risk for infertility will be counseled about potential fertility preservation and can then make the choice for undergoing one of the recommended options. For further successful implementation, it is important that the guidelines are accessible to those who use them. Implementation of the guidelines can be facilitated by decision support systems, for example, that can replace the sheet I was just showing. So within these computer systems, the cancer treatment is linked to recommendations and then generating an individual care plan. Moreover, it's very important to communicate guidelines to patients. Developing patient versions can enhance guideline adherence. And it is important to use decision aids based on the guidelines in order to facilitate the shared decision making. So special thanks to the chairs and advisors of the guideline panel and all the members, of course. And these are all the co-authors, the guideline panels that contributed to the development of this guideline. So thank you all.
Thank you so much for that wonderful webinar and all this great information. Do any of our participants have any questions? Look in the chat and see. So I have a question. So for ovarian tissue cryopreservation, do you have any like firm guidelines for like who are the absolute best patients to do this, or some patients who wouldn't be good candidates?
Not per se, we've not included that in our guidelines, but I know that in our clinic they use, if I'm correct, the Edinburgh criteria. So before undergoing a procedure, so the survival rate should be high, they should be in well condition, and the risk of infertility should be high. But no, we did not describe a specific patient who benefits the most. I think from the evidence, we don't know. Maybe in clinical practice someone has experience, but no, I cannot say.
Great. So here's a question in the chat. There was a mention about menstrual suppression as a means of fertility preservation, but I thought that COG and other organizations have recommended against it as a primary means of fertility preservation. So I think she's referring to like GnRH agonists.
Exactly. So for here showing the recommendations for males. Oh no, they are not included here. Yeah, so for males we recommend against, because there is no evidence whatsoever that it's effective. For females, the evidence is not convincing. So they're in childhood cancer patients. There seems to be no clear benefit, but the evidence is very low quality. In elder populations, the effects are some studies suggest a protective effect of GnRH analogs, while others don't. So we recommend it to. I really have to check it. We said that we could not formulate a recommendation for clinical care for the female patients, but it could be done in a research setting to gain more evidence. So it's not a recommendation against, because for the females there's more conflicting evidence, and for the males there is evidence that, or there's no evidence of any effect. So we recommend against for the males. Yeah.
Great. Thank you. Thank you so much for the explanation. There's another question in the chat. Just quick, close this one. How can you see the impact of applying these guidelines on your patients?
Really good question. I should ask my because I'm not a clinician, so. But it's a really good question to ask. For example, Marianne van der Wetering, she's the chair of the oncofertility unit in our hospital, and she sees a lot of patients. We should also, like I've shown on like one of my first slides. Let me go there. Here, so we should evaluate. In this last bullet, evaluate the quality of care. So do patients at high risk for infertility, are they really offered any procedures? And if so, still they have the choice to undergo a procedure or not. So it's more difficult to measure, I think, if the guidelines are really applied or followed in clinical practice. But still, this is a good next step to see if the guidelines are used in practice. Yeah. Maybe someone else has an opinion about this.
Thanks a lot, Renée.
You're welcome.
Yeah, you have really a very great talk. And the model that you introducing about your center in Netherlands is very interesting, I think, to us and to many other people who are trying to establish an oncofertility program at their institution or even their country. And I think it's very obvious how much the effort you and your group have made on the national level to establish this great thing. What do you recommend for many centers or small clinics that they are planning to start the oncofertility program? What they should do on the national level first before starting their program on their local level at their institution?
Yeah, so I think it's first of all, it's good to assign like a team that is responsible for the oncofertility care, and that that group of doctors or nurses or healthcare professionals, I should say, educate themselves so they will become the experts, and that group of people is responsible for the counseling of the patients. And so even if there's no oncofertility unit in the hospital, or I think it's also good to how do you say, connect to other centers that may have, so you can refer your patients to another center or unit in another hospital for the fertility preservation procedures. But the counseling and the information can be given by the local doctors, local healthcare professionals. So that's my personal opinion based on my knowledge in the guidelines. But
Yeah, that's really great, because I think the national referral system is very important, and having a national center of excellence like your institution in Netherlands, I think it's essential to refer all patients to one big institutions or few big institutions in the country that have experienced team and equipment to provide the service for patients, and also to keep the data as a registry and then follow up on the cases afterwards. Great work. I'm fascinated. Thank you so much.
well, thank you.
Can you tell us a little bit about how in the Netherlands, is there an issue ever with access to care for fertility preservation treatment? For instance, in the United States, a lot of times it's not covered by insurance. In some states, there's a mandate, but in other situations, patients may have issues with the financial challenges of fertility treatment.
Yeah, so the same for the Netherlands. So that's one of the huge advantages of having such a guideline, that, for example, for ovarian tissue cryopreservation, now with having a guideline recommending it to certain patients, it can become insured care. But beforehand, ovarian tissue cryopreservation was not insured in many cases. So therefore, such a guideline is really important, and the insurance system is for every patient in the Netherlands is the same. So the basic insurance. I'm not sure about the costs of storage, if that is insured for everyone. I don't think so. No, so but at least for undergoing the procedure, and then the storage is a good question. I have to figure that out. No, I have no idea. but yes, it is difficult for new new procedures like fertility preservation. It is a hot topic. Yeah.
So in the Netherlands, do you ever, so for instance, so you said that ovarian tissue harvesting is usually covered by insurance or not covered?
Now with guidelines recommending it to certain patients, it is covered. Yes.
Oh, great.
Yes. Yeah. And that's the huge power of such a guideline, so that care can be ensured. Yeah.
That's great. I think, was there a question about what are your next guidelines?
Oh, so our next guidelines. Oh, yes. So we are about to update the premature ovarian insufficiency surveillance guideline for survivors. And after that, we would like to start with the fertility preservation for female survivors who missed the opportunity before or during their cancer treatment, to make a guideline for this group, because at least in our center, and also I know from other centers around the world, people are asking, okay, or patients are asking, survivors, like, I've missed the opportunity, what can I still freeze my ovaries or do something to preserve my fertility? And there is no guideline. So that's also high on the list. And besides that, the IGHG is working on many other survivorship related guidelines as well. Yeah, but for fertility, those two are high on the agenda. Yeah, and then the first one, so the premature ovarian insufficiency is about to start at the end of this month, beginning January.
Do you think you'll also have guidelines for patients who have medical or genetic conditions that may put them at risk for having ovarian insufficiency, like patients with galactosemia or Turner syndrome, mosaics, whether there would be guidelines for those patients who don't yet have POI but could develop it?
Yeah, so at the moment, these are pediatric oncology guidelines. So
got it.
Yeah, so that's we develop them from pediatric oncology. But yes, of course, I can imagine that those groups can extrapolate from those patients who can extrapolate from our evidence and clinical recommendations, and maybe in the future we are open to everything. So yeah, maybe we expand.
Great, thank you. Wonderful. Are there any other questions from the chat or from any of our audience members? This is a wonderful talk. I don't think there's any other questions. And so at this point, we could end the webinar, but it was wonderful to have you. Thank you so much for sharing your knowledge and experience.
Well, thank you so much for the opportunity to share it. Okay, thank you.